Good evening, everyone,
Good
and
evening.
very warm welcome to our no thrombosis program. And no thrombosis program is one of the most engaging scientific platform where it has been awarded by SIMS Healthcare Excellence Award on 2021. Every month, we are doing at least minimum one program of no thrombosis, specifically dedicated to all thromboembolic cases, where we do discuss on the cases of the CAD, PAD, DVT, pulmonary embolism, NVA. So today our moderator is Dr. S. Arvind sir. He is MD and DM cardiology, interventional cardiologist in Apollo Hospital, Varangam, Chennai. Sir has participated in many conferences as a faculty, as well as he's published many articles. Also, he'll be in the some kind of Also, Dr. Arvind sir has participated in A1 as an investigator in a good number of trials also. And so on behalf of welcome Emcure, I welcome to Dr. S. Arvind sir
Good evening, everyone.
Our first speaker is Dr. Yes, sir. Good evening, sir. So our first speaker is Dr. S.K. Sarjan Basha. Dr. Sarjan Basha is done MD in medicine, DNB in cardiology. He is a consultant physician and interventional cardiologist from Peacock Hospital, as well as Tirutani Taj Cardiac and Diabetic Clinic, Arakonam. So welcome, Dr. Sarjan Basha, sir, for today's program.
Yeah, good evening, sir. Good evening.
Yeah. Yes. So our next speaker is Dr. T. Pramod Kumar Rao. He has done MD, DNB in medicine and DM in cardiology. He is a consultant interventional cardiologist from Omni Hospital, Kujatapalli, Hyderabad. So welcome, Dr. Pramod Kumar Rao, sir, for today's program.
Yeah. Good evening, everybody.
Good evening.
Our third speaker is Dr. S. Prabhu Venkatesh. So Venkatesh, sir, he has done MBBS in Deep in Cardio and FISC fellowship he has completed. Sir is also a consultant cardiologist working in SAS clinic as well as the cardiac care center in Dharampuram. So sir has a vast experience specifically in the the field of thromboembolic complications, and also sir has participated in many conferences as a faculty. So from behalf of Emcure, I welcome to Dr. S. Prabhu Venkatesh, sir, for today's program. Welcome, sir.
Thank you very much. Sir. Thank you very much.
Yeah, and today's agenda is that the first case will be Dr. S.K.M. Sarjan Basha, sir. Next case will be Dr. T. Pramod Kumar Rao. Dr. S. Prabhu Venkatesh will be a third case. Before going to a case presentation, I request our moderator, Dr. S. Arvind sir, to open this today's no thrombosis program. Thank you, sir, and over to you, sir.
Yeah, good evening, everyone. So as we all know, today the order of the day for myocardial infarction. This thrombolysis is one of the most life-saving things where during our course, during our MBBS times as well as during our general medicine times, so where people could not reach any of the cardiac centers. Even today, many of the nursing homes and nursing centers where cath lab facilities are not within reachable time. So thrombolysis is one of the most useful and beneficial things which is in existence, and it should be continued. With invention of the newer molecules, compared to this streptokinase, all this plasminogen activator inhibitors like alteplase, breteplase, now coming to the latest tenecteplase, which has come as a stat dose, is much more useful. And where we used to see a lot of reactions with those days with streptokinase patients having allergy, where we cannot go for a repeat thrombolysis. In all such cases, this tenecteplase is a big game changer. With this note, I think we can invite Dr. Bashaji to take over for the presentation.
Yeah. So I just share my screens. I think you're able to see my screen.
Yeah. We can see it.
Okay. So regarding a massive thrombus, today we'll discuss my topic. I want to discuss one part of the management of a thrombus, that is acute MI with a massive thrombus. The role of intracoronary thrombolysis, which is mostly neglected nowadays. So as by definition, if you take a thrombus, usually it is consists of combinations of platelets, red blood cells, vasoconstrictors, procoagulants anchored to a scaffolding matrix of crisscrossing fibrin fibers. So depending upon the presence of platelets and red blood cells, these are categorized into a white thrombus and red thrombus. So in acute MI with the massive thrombus, mostly what we see is a red thrombus. So this is a same old TIMI thrombus grading score. And massive thrombus usually indicate grade 4 and grade 5 thrombus. So grade 4 is definitely a large size thrombus. The greatest dimension of thrombus is more than two times the vessel diameter. And grade 5 is a complete thrombotic occlusion of the vessel, which is nothing but a convex margin that stains with the contrast and persists for several cardiac cycles. So this grade 4 and grade 5 usually indicates massive thrombus, which we'll concentrate now. So in a patient with a massive thrombus, how we manage this? We go for pharmacotherapy, mechanical thrombus extraction, stents with thrombus capturing mechanism like Emcure stents. So in pharmacotherapy, especially in patient with a massive thrombus, we need a potent antiplatelets like ticagrelor and prasugrel. And heparin should be adjusted to the ACT, and glycoprotein 2B3 inhibitor can be used. And intracoronary thrombolysis, it is not yet recognized in the guidelines and mostly it is neglected. So among mechanical thrombus extraction, the most commonly used is a manual aspiration catheters. And next is a power source thrombectomy, ultrasound-induced sonication, and embolic protection devices, which is mostly used only in bypass graft. So among manual aspiration catheters, export catheter is the most commonly used. And why it is most commonly, these manual aspiration catheters are used because it has most advantage, because it is a user-friendly, low crossing profile, hydrophilic coating, it is flexible, it has tapered distal tip. So hence is most commonly used. The limitation is a difficult delivery along tortuous vessel, and the reduced ability to aspirate at distal coronary segments and catheter-induced distal embolization. So because of this only, among the four mechanical protection device, manual aspiration catheter is most commonly used. So the TAPAS trial usually favored, but TASTE and TOTAL trial deferred routine manual aspiration before primary PCA when compared to primary PCA. And you can able to also see that in the TOTAL trial, the percentage of stroke in patients are also found to be more. The several meta-analysis also deferred manual aspiration. Hence, the European guidelines in 2017 itself pushed manual thrombus aspiration to class 2B indication. So, in the management of patient with a massive thrombus, we need a still forward go, because even what we are using currently, thrombus aspiration does not have class 1 indication. It has been pushed to class 2B indication. So, what else? Next is a power source thrombectomy. This is most commonly used as a rheolotic thrombectomy, excimer laser, exciser. These works very well in a large thrombus. The larger the thrombus, higher is the extracting yield. But the problem is these are bulky devices and it needs express to use it, because much center don't use it. So in a patient with a massive thrombus in a day-to-day practice, so what else we can do? So intracoronary rises definitely has a role in a patient with a STEMI with a massive thrombus, which I will demonstrate through a case. So this is a 38-year-old male, non-diabetic, non-hypertensive. He was admitted with a history of typical retrosternal chest pain with sweating since 3 hours. And its pulse was 60 per minute and blood pressure was 110/80. ECG was normal sinus rhythm with acute inferior wall MI. And echo revealed regional wall motion in the inferior territory with adequate LV function. And he was planned for primary PCA loaded with a clopidogrel 600 mg and aspirin 300 mg. So his left coronary system is found to be normal. Oh, right. It's not yeah. It's not a name. See, this is the right coronary artery. Right coronary artery, you can able to see almost it is totally occluded from the mid segment with thrombus, and in the proximal part you can see able to see a 70 to 80% lesion also. And so the patient, this patient wire was the PTC was planned, and 0014 Renato PTC guide wire was passed, and a semi-compliant balloon was almost placed and dilated. So this was a flow following balloon dilatation. The PDA and PLB is found to be opened up, and it is opened up. Yeah. So we plan to put a stent, and a stent of drug-eluting stent of about 2.5, 28 millimeter stent was placed from the distal RCA to the proximal PDA. So another stent of about 2.75, 28 millimeter drug-eluting stent was placed from the mid RCA to the distal RCA. And this point of time, you can able to see there is a thrombus in the proximal part of the RCA. The plaque has ruptured and thrombus is in the proximal part of the RCA. So this was post-dilated with a 2.75, 12 millimeter non-compliant balloon at 14 atmosphere. In another, and this is a result of following post-dilatation. You can able to see a thrombus in the proximal part of the proximal stent and thrombus in the proximal RCA. What happened in another few hours, the patient went to hemodynamically unstable, and check angio showed this was a result. There was a total occlusion in the proximal part of the RCA. So the patient had went for bradycardia and complete heart block, and a temporary pacemaker was kept, and inotropes noradrenaline was started. So the lesion in the proximal part was covered with a 28 millimeter drug-eluting stent. So now the RCA is full of metal jacket, and this was the final shot after giving intracoronary Nicor and everything. So you can see only the flow through the stent and the slow flow, and there is no myocardial blush. So what we thought is I will keep a overnight GP2B3 inhibitor. GP2B3 inhibitor teriflunomide was kept overnight, and check angio was planned next day. So this is a check angio on next day. So you can able to see there is a total occlusion proximal to the stent. So again, this time it was very challenging. So as I think when a patient with the stent thrombosis, what we do, we usually go and balloon dilate him. So just we passed the wire, we balloon dilated with the non-compliant balloon, and thrombus aspiration was done almost 3 times. So, but there was no flow. So usually we have experience with intracoronary tendinopaths. Usually we use intracoronary, mostly tendinopaths, sometimes septokinase. So usually how we give is we give 1/5 intracoronary. We just check angio that time itself. We'll see if we see the flow, good flow, then we give the IV dose remaining 5/6, and then take a check angio after 4 hours. So we just planned, after explaining the pros and cons, we just planned to give the intracoronary tendinopaths. And this is a shot after giving intracoronary tendinopaths. So just you can see there's a trickle of flow, opening up of PDA, and there's PLV also. So we gave remaining tendinopaths 5/6 IV, and we take a check angio after 4 hours. So this is a check angio after 4 hours. You can able to see the beautifully open up arteries. Okay, so there is a beautifully open up artery with a good myocardial blush, and the stent is very well expanded. So intracoronary, I think in this patient, intracoronary tendinopaths usually worked as a bailout almost for me because there is no option. We are given post stenting, or everything has been post dilated, GP2B3 inhibitor given, and there is nothing more. So this patient's one clue is this patient is a young MI. So any patient with a young MI, usually the thrombotic burden will be very high. So that was a clue for us. So we just, in spite of taking risk, we went and just gave tendinopaths, and we had a very good result actually. And post follow-up 4 to 5 years, this patient is doing well. So if you go through literature, there are only no randomized control trial. There are only small case series and case reports about intracoronary tendinopaths. And the most common drugs used are streptokinase, tenofovir, and alteplase. And we have a huge experience with intracoronary tendinopaths, and mostly we use Alexa. So this is our own paper. We want to publish in Indian Art Journal. So initially, we published a paper of intracoronary tendinopaths in STEMI with massive thrombus. So a patient with a massive thrombus, a case series of 8 patients where we gave intracoronary tendinopaths. And among them, 7 people, we avoided stenting. Just by giving etranacogene and replace, thrombus washed away. There was no lesion and the patient was fine. And on follow-up of 6 years, the patient now okay. One patient where after thrombus lysis, there was a lesion at the site. And since the distal margin was very clear, the stenting is easy. You can place clearly a stent from left main to a lady. That was the thing. And we extended that use even to patient with the stent thrombosis. So patient with the 3 patients with stent thrombosis, we used intracoronary lysis. It completely cleared the thrombus and we just avoided stenting. So this is our own publication in Indian Journal. So just I want to convey, when a huge thrombus is detected on coronary angiogram, intracoronary diuretics could be administered immediately with a better chance of early restoration of blood flow. Distal embolization by wire crossing, balloon dilatation, and thrombus aspiration could be avoided. And combined therapy, that is preceding lysis and subsequent angioplasty, when compared with primary angioplasty, produces better restoration of flow in STEMI with massive thrombus. So management of acute MI with massive thrombus is a challenging scenario for anyone. And in these patients, we usually use a potent antiplatelet like ticagrelor and prasugrel. And GP2B3 inhibitor should be used whenever needed. Mechanical thrombus extraction is used, but it has huge limitations in the current era. And intracoronary lysis definitely has a role in acute MI with a huge thrombus burden, which in small studies has shown to improve TB flow rate and myocardial pressure rate. Thank you. Arvind sir, you're on mute. Arvind sir, you're on mute.
So excellent case actually. This is one of the most difficult case that we used to see in our routine practice, and very difficult to even explain to the family and the attendants that the stents are getting blocked. They immediately try to doubt the doctors rather than thinking about the burden of the this thing, which is one of the most. It's a very good demonstrated case. Only thing, like, what is the dose of intracoronary? Like how much milligram of this thing? How you chose based on the weight, or how you decided?
Yes. Yeah, actually, there is no, since there is no randomized trial, there is no guidelines, there is no correct protocol. Some studies usually give 1/3 intracoronary, remaining IV. So what we do is actually we give minimal dose intracoronary. So we just check a angio and see how is the flow. Remaining we give IV. So that it is safe for us to have a complete thrombolytic therapy.
Right. Anyway, that's a good case. Good case, doctor. Thank you.
Very nicely presented, sir. Thank you.
So one question from me. So what is the window period in all these 8 cases you have done a thrombolysis, you told?
Yeah,
so this case is 2 to 3 hours.
Yeah.
2 to 3 hours in patient, na? Probably you might. Yeah.
So ideally, whatever we take it for IV thrombolysis, we take it for this also. Usually 12 hours, but we usually categorize patient with 6 hours. Usually. So mostly we take most of the patient with 6 hours. I mean, don't take up to 12 hours because at that time muscle thickness and all, it is an issue and all. So usually we categorize up to 6 hours.
Yeah. So one more point I would like to add here is, like, in our routine practice here at Apollo also. So what we do for this patients with presenting with recently stented who come with again a STEMI. Recently we had a patient, similar patient, stented osteoproximal LAD, presented with stent thrombosis. So we have to thrombolyze the patient. After thrombolysis, the next day, if you take for an angio, it will be a clean stent also will be patent in such cases where you could not. Then we did an OCT for that, and there was no much of evidence of any stent fracture or geographical miss or this thing. Only a loose thrombus was, white thrombus was present. So we kept him on good anticoagulation, and the patient is doing well. This is 3 months back, what I say. So in cases of post stenting, and if you could recently stented, and if in such patients we have MI in the same territory, I think thrombolysis followed by angio will also is really beneficial, which many of the studies have not, as we know that many RCTs have not conducted in this area. So this is really beneficial, and especially in post CABG patients also, where we will tend to see graft occlusions, the patients who present with us in the particular territory. So we try to thrombolyze them and then take stabilize them and then take for an angio. So where we could see entirely, because the thrombus burden of the SVG grafts are much more higher. It's something similar like what our Dr. Basha had experienced, where we try to stent at one point and the remaining exclusive things will get occluded, and the reocclusion chances are also very high in such categories.
So in this type of patients, we should evaluate for the thrombotic tendency also, because the younger patient with the stent thrombosis. So I had a similar case 10 years back. This is at the time we are using STK. So immediately night I did a primary. By the morning, patient has got same RCA. So at that time we given a streptokinase and we have got a good result. We evaluated that patient. That patient has got some thrombotic tendency. Hyperhomocysteinemia is there with family history. We kept him on anticoagulation almost for 1 year. Then that is the follow-up case. Now he is doing nicely.
Yeah.
Especially these types of scenario, actually, when we have to think is, one is when the patient is young MA. So young MA, ideally these patients, young MA patients usually have a huge thrombus burden. And there is a ectatic coronaries. If you have ectatic coronaries, that point, MA with ectatic coronaries, that point of time, going and putting a stent, everything will be a big problem for us. So that time, I think we can able to think the thrombolysis.
So recently also, I had one during this COVID time. I had even almost 6 to 7 patients similar to what like Dr. Basha has explained. So because all are young patients, less than 35, who presented with MI. So with all these patients, we did an angiocardiogram at the presentation. Then we thrombolized the patient, but I didn't give intracoronary. But we did a routine tenecteplase routine thrombolysis. So at the end of the repeat angio after 3rd day or 4th day, where you could see a clean vessel, where we could not see even an iota of, because these are all young patients, the moment you try to stent, and almost now 1 or 2 years with this follow-up, and initially I kept them on all anticoagulation, plus as we said, hyperuricemia for which treatment was started. And the patients are doing really well now. We avoided stents in all the 6 or 7 patients. Only I think 1 patient had a repeat problem, even if I remember correctly. But I didn't publish it, but I have that data to be published. So this young people, especially the role of thrombolysis is really good rather than going for stents, because once you stent them across in the young age, the lifelong they have to be on antiplatelets, statins, which is going to be a big game changer in their lives actually.
But even other ways, right, sir?
Which one, sir?
You said for stents, sir, even if you thrombolyze him, we put a tag that he is an MI patient and we continue to give him antiplatelets and statins.
Sir, but the moment you place a stent, sir, what happens is like all the stent related complications, stent thrombosis, restenosis, progression of the all these problems will be there. Whereas allow it to be a natural vessel, if we could achieve a good result with thrombolysis, then we could, yes, definitely with a single antiplatelet over a period of time, you will do well. At the end of 10 years, he might not even require anything. If he does not develop any risk factors, he might not even require any even antiplatelet therapy.
Yes. You're right.
Yeah. So we can proceed with next presentation, Mr. Ravi. I think Pramod sir can start. We can.
Yeah. Ravi, you can share the slides now from your end.
Yes, sir. Yes.
Yeah. Yeah, after acute MI, we are discussing the NOVAX. So another area of maintenance of the anticoagulation with the age-old drugs we are having since 15-20 years of experience with vitamin K antagonist. And since 10 years, there is an era started with novel oral anticoagulants or DOVAX or NOVAX. So in the market, we have got 3 agents, that is the dabigatran, apixaban and rivaroxaban. So we will discuss the case and we proceed with these things. So case 1, the 29 years female with the gravida 2, para 2, 19 weeks of gestation. So complaining of left leg swelling, pain since 5 days, and there is associated with the bleeding PV also. So the history will tell that this is nothing but a pregnant lady with 2nd trimester with left leg pain that indicates it might be a DVT clinically if you examine and do the ultrasound, and So associated with the bleeding PV, what is the cause we have to evaluate here. Next slide. Yeah, on examination, so hemodynamically stable, JVP is normal, respiratory and cardiovascular system is normal, saturation is good, and left leg thigh and calf swelling with redness and tenderness. Clinically, it is a DVT with the hemoglobin of 8.2 grams. Next slide. Yeah, ultrasound venous Doppler shows that left common iliac femoral popliteal vein extensive thrombosis. The proximal DVT with involvement of the left common iliac vein with second trimester pregnancy with PV bleeding and low anemia. How to tackle these patients? Usually, if the bleeding is not there, anemia is not there, then we can proceeding with giving up normal low molecular weight heparins and catheter-directed thrombolysis, and we can clinically how is the response we can see, and we will put him on the anticoagulation the entire pregnancy period, and we will see. Here there is a risk of PV bleeding is there, so with anemia. So what are the options? Next slide. Yeah, that's what problems. Pregnancy, second trimester, bleeding CV, extensive proximal DVT, risk of thromboembolism will be there, and a risk of bleeding. Already there is a PV bleeding is there, and risk of miscarriage. Next slide. The plan of management, that is the thrombolysis, catheter-direct thrombolysis, and the anticoagulation options are either unfractionated low molecular weight heparins. So whether vitamin K antagonist, Novax. So it is a second trimester pregnancy. Still, we can use a little these drugs. If it is a first trimester, there is no option. We have to use only low molecular weight heparin or unfractionated heparin. And the prevention of thromboembolism. So what we can do in this patient is IVC filter insertion. So anticoagulation, what is the duration of the anticoagulation, and what anticoagulant has to be chosen and follow up. And so in this patient, there is a bleeding is there, anemia is there. We can't give this thrombolysis, catheter-direct thrombolysis. The risk of miscarriage and increase in the bleeding will be there. So that option is out. And then the other option is the clinically we should monitor by giving these drugs. Because of the proximal thrombus, it may extend and risk of pulmonary embolism will be high. So we can put an IVC filter, retrievable IVC filter for the duration of pregnancy, and afterwards we can remove it. And so during that time, and we can wait and watch what is the cause of PV bleeding has to be evaluated. And once that is corrected, we can give a low molecular weight heparins. Next slide. Yeah, this is, you can see there is a risk of radiation will be minimal. We can do a IVC filter insertion in this patient, and we can give a risk of PV bleeding is evaluated, and low molecular weight heparins are given. Then patient has recovered very well, and this has continued until the pregnancy. Next. So that is the case. If it is the PV bleeding is not there, and we can do a catheter-direct thrombolysis, and giving up these drugs is the option. But because of the bleeding and anemia, putting a filter, that filter can be removed after post-pregnancy, and we have given the drugs. So next case is 63 years female. Yeah, there is a history of dyspnea since 2 days. The patient is tachyapneic, pulse of 140 per minute, tachycardia, tachyapnea. So hemodynamically, there is a lower side BP 90-60 with the respiratory sounds are normal. CVS is a gallop rhythm. And this is a case of pulmonary embolism. Next slide. So here there is a catheter-directed patient is hemodynamically unstable. Catheter-directed thrombolysis is done with tenecteplase. So next slide. So this is into LPA, RPA, right pulmonary artery. Next slide. So thrombolysis, systemic or catheter-directed thrombolysis, especially if it is a large patient, if you actually this has to be diagnosed with suspicion and CT contrast, CT pulmonary angio. If it shows a big chunk of thrombus, it is proximal, then catheter-directed thrombolysis is better. We can give a systemic also if it is subacute this one. So hemodynamically stable one. So here and then the anticoagulation option. So we can continue with low molecular weight heparin, vitamin K antagonist Novax. So Novax has a good role once you systemic or catheter-directed thrombolysis has done and patient has recovered very well. Then you can switch over into this Novax can be started as early as along with this thrombolysis, and we can continue. So then we can evaluate what is the cause of this pulmonary embolism, and underlying cause has to be corrected. And Novax, duration of the Novax will be depends upon the what is the cause. So if you won't find any cause, then you can give 3 to 6 months and you can stop and wait and watch. But if you find any hypercoagulable conditions, we have to give a lifelong. So if it is a that is again in this whatever it may be, whether it is a DVT, pulmonary embolism, or arterial thrombosis, if you find this hematological conditions where we have got a genetic survival like factor V Leiden deficiency, resistance, and antithrombin 3 deficiency, and hyperhomocystinemia. So all these conditions still we have not evaluated the Novax in those conditions. Still vitamin K antagonist they will say, but we can try. The papers publishing are not there Novax usage in these conditions, but we can try in those because they have to take a lifelong these drugs. So better to use a Novax. Then the duration of anticoagulation depends upon the cause and follow-up of this patient. Patient is doing very well. So initially mild RV dysfunction that has recovered during the time of discharge and is doing well, and the pH is very minimal. But even in subacute pulmonary embolism where thrombus burden is very high, where a patient is hemodynamically stable, even in this type of condition also, if you do a thrombolysis in the follow-up cases, the thrombus burden will be less, and the pH, the thromboembolic pulmonary embolism with the pH, chronic pH will be very much less if you do a thrombolysis. The next case. The case 3, if you see here, the 65 years female systemic hypertension. With the pain in the left hand forearm with the blue discoloration of the left fourth and fifth finger. So this is nothing but there is a the pain with little bluish discoloration. So that indicates the there is the acute limb ischemia. So arterial Doppler has shown decreased flow velocity in the subclavian artery with 80% of the stenosis and no flow in the radial and ulnar artery with thrombus. Next slide. So where we can see here the angiogram has shown there is a lot of thrombus burden with stenosis, and the distal flow is not good. Next. So there we can give these type of cases local thrombolysis we can do with catheter-directed thrombolysis, followed by if the result is good, then we can leave. But if the result is not good, then we can put a stent across the subclavian artery proximal part and we can come out. In this patient, we did a thrombolysis. The distal flow has started. So after 2-3 days of after catheter-directed thrombolysis, 3 days after that check angio shows still there is a persistent of lesion. We stented across the subclavian artery, then the patient is doing well. Next. So then the cause has to be next slide. Yeah, in these type of cases, we can see the lesion is within the proximal part, or if it is the peripheral part also, the distal, ulnar and radial is not palpable. At that time, we can cross the thrombus with the wire, and we can distally you can send the catheter and you can inject and see whether the distal flow is good. If the distal flow is good, then only the thrombus pertaining to that part we have to treat direct thrombolysis or stenting. The distal vessel disease also there, then the other things we have to think of. Next. That's what systemic or catheter direct thrombolysis, same giving of these drugs, and duration of the Novax, we can think of in the long-term management of this type of patient with acute limb ischemia. Once treated, underlying blood flow has restored, we can give a Novax of duration. And so again, we have to evaluate what is the cause. Mostly 63 years female, the left-sided involvement of the subclavian artery, probably if the entirely distal disease, proximal disease is there and osteal disease, then anything aortoarteritis has to be evaluated in this patient. And if it is only the local thrombus, if it is there, then you can do it as a normal. And the thrombus burden will be high because of the catheter, this diameter of the artery. So direct stenting is always avoided. So you do a first thrombolysis, catheter direct thrombolysis, then good do if it is the persistence of the lesion, you do it the stenting, then the results will be good. Or if it is the patient is not getting any flow, better go for the fog artery embolectomy, where you can remove the thrombus, chunk of thrombus, then immediately restoration of the flow will be there. Then afterwards, you can think of giving all these drugs and do a check angio after 3-4 days, and if the lesion persists, then do the stenting. So this patient after 3-4 days, the flow is good, and we stented only the proximal part. Distal part is neat and good. Even during the before thrombolysis, we injected the dye. We crosses the axillary artery and we injected the dye. The distal ulnar radial is good in flow. So the proximal part, if we treat, then he recovered nicely. And Novax has started in this patient. We have given for 3 to 6 months, and then we stopped. Afterwards, he is on ecosprin, and follow-up is good. There is no evidence of again embolic episodes in this patient. Next slide. So after all these cases, so one is the DVT with pregnancy, pulmonary embolism, and arterial acute limb ischemia with arterial thrombosis with the distal embolization. So after all these conditions, in the maintenance of the anticoagulation, we have got the 2 agents, that is the vitamin K and non-vitamin K antagonists, the newer oral anticoagulants. The 3 drugs available is the dabigatran, rivaroxaban, and apixaban. Endoxaban is not available in India. So these are the dabigatran is a direct thrombin inhibitor. These are the rivaroxaban and apixaban factor 10A inhibitors. So how these drugs are good when compared to this warfarin? They are more efficacious and more safety. So they are non-inferior to the warfarin, whether we take a trials, whatever it may be, in the DVT or pulmonary embolism, arterial embolism, or AF, they are non-inferior. At the same time, they are very much reduced incidence of intracranial septal hemorrhages are noted. They are very much safe, these drugs. In these drugs, in the 3, there is no head-to-head comparison of these drugs. But if you see the literature, if you compare with warfarin, so in these of all these 3 drugs, the apixaban has scored little bit safety, especially in the older individuals, geriatric individuals, and also in the renal failure patients. As the renal clearance come down, the other drugs has to be avoided. And the apixaban can be given in even patients with hemodialysis. So especially elderly people with high risk of bleeding. So the patient is on other drugs who have developed a GI bleeding or something, we can switch over into the apixaban. That is what the beauty of apixaban. So we can give. Next slide. Yeah, this is the pharmacological properties of these 3 drugs. We have already discussed the dabigatran is a direct thrombin, rivaroxaban, apixaban factor 10A inhibitors. So dabigatran is a pro-drug, the others are no. And if you see, these are the dabigatran and apixaban has to be given twice daily and rivaroxaban once daily. Just coming to the renal excretion, there you can see the 80% of the dabigatran is excreted to the renal excretion. So in case of renal failure, we have to, once the eGFR has come down less than 50, there is no role of dabigatran. So still apixaban can be given beyond 70, 75 end-stage renal disease or hemodialysis. Still apixaban can be given, rivaroxaban up to 75. If it is less than 30 eGFR, then we can avoid rivaroxaban also. there is a liver metabolism is there with this one. So end stage liver disease, we can confine this decreasing the dosage of these drugs. Next slide. Next slide, please. Yeah. See, if you see, there is a gastrointestinal tolerability is not a problem with rivaroxaban or apixaban. Dabigatran, because of his tartaric acid is there in this as a prodrug, where local dyspepsia, local erosions is noted if the gastrointestinal tolerability is less. And absorption with food, rivaroxaban has to be given along with the food because bioavailability will be more if you give along with the food. And the dosages are dabigatran 150 BD or 110 BD, rivaroxaban usually 15 mg. If in case of this DVT and pulmonary embolism, we can give this rivaroxaban 15 mg BD for 3 weeks, then followed by 20 milligrams OD, whether we can continue depending upon the cause of 3 months to 6 months. Then apixaban, usually 5 milligrams BID, we can give whether AF or DVT or pulmonary embolism in the maintenance dose. Usually in few studies, they have given initially up to 10 milligrams BD for 1 week, then followed by 5 milligrams BD. But we as a consultant, we are using 5 milligrams BD. Next slide. Yeah, if you see the Amplify trial where the Dovax, previous slide, please. Dovax versus standard anticoagulation, the efficacy in the VTE recurrence of death. If you see apixaban when compared with warfarin, so this safety is the efficacy same at 2.3 and 2.7% with VKS. If you safety outcome, if you see the bleeding, major bleeding, intracerebral hemorrhages are less, 0.6 with apixaban, 1.8 with the VKS. So that's why they are efficacious and with the reduction in the complications, bleeding complications. Next slide. Next slide. So this is the limitation of VKS. We know that there is a food-food interaction, drug-food interaction. We have to monitor PT-INR regularly. Most of the time, patient will be out of the INR targeted therapeutic ratio. We have to maintain at least 75%. 75% of the time he should be in TTR to be effective. It is more risky if you are suspecting a long-term anticoagulation. Once the novel anticoagulants come, all these things, drug interactions are less and it can be given safely. There is no monitoring of INR, food interactions, and so broad therapeutic window. So minimal influence of the other drugs and food and less intracerebral hemorrhages. So that's why we can choose especially the limitation of the VKS now come down to only the patients with mechanical heart valves with this metallic valves where the patient, that is one area, and another is the severe MS with the AF. Even with the moderate MS also we can give this Novax, but as such. And other areas where hereditary things are there, like factor V Leiden deficiency and hereditary like Aplas syndromes and rheumatological conditions where these conditions are there, then there the role of VKS will come. Otherwise, we can, in all other situations nowadays, we are using the Novax. Next slide. Yeah, I already explained this. Apixaban is a little bit Aristotle trial has shown where the old geriatric patients also, it is very safe in the patient who predicts the recurrent even falls also, where we can see the low risk of subarachnoid, subdural hemorrhages, subdural hematoma, recurrent falls patient also. So it is a safe in prevention of stroke or systemic embolism, AF or VTE or DVT and pulmonary embolism, especially elderly and renal impairment. So because of the fast onset of action and offset of action, it is safer to give these drugs even if they are going for an elective surgery. Something we can stop for 24 to 48 hours, then we can give a clearance. And if it is an immediate, some life-threatening and some cerebral hemorrhages, where we can have some of the antidotes for the dabigatran, and even with reversal agents are coming with these, and we can give that one. So thank you.
Thank you, sir. It's a wonderful presentation of 3 different areas of where you covered extensively, like pregnancy-related DVT plus pulmonary embolism plus arterial thrombosis. Only one thing, the first case, like during the pregnancy, when the patient developed DVT, so you said like you went ahead only with the filter, sir. You didn't keep them on any anticoagulation.
That's what she has got a active PV bleeding and second trimester. That's what.
Okay.
So if you give at that time further, there is initially we put a filter. Then once the PV bleeding has stopped, we started with low molecular weight heparins. Slowly we build up and we corrected the anemia. Then we maintenance. So after the pregnancy, we develop that filter.
That is a situation where there are no clear guidelines or no clear. During pregnancy, where going for doing an IVC filter, also the radiation induced all these things, the precautions needs to be taken, and it's
it is,
and the second case, like the pulmonary embolism, where you said one point which I would like to this thing is like where you said it's not only massive pulmonary embolism, even for nowadays what we are doing here, though it is not mentioned in any of the studies, people whoever is presenting with a DVT, we are trying to do a CT pulmonary angiogram, of which majority of them has at least a minimal thrombus or a moderate pulmonary embolism thrombus is there, though which is not picked up in the ECG or echocardiogram, where there is no clear indication for even thrombolysis. So even subacute with the newer anti-thrombolytics like tenecteplase, I don't see any major induction of any bleeding in such cases also. So giving up 30 milligrams of patient tenecteplase really goes a long way in preventing our chronic pulmonary thromboembolism induced PH. So as you have clearly mentioned, so I think even in moderate cases, once the pulmonary embolism is established, I think we should go ahead rather than. I think that's a good point what you have established. I think things are okay. Dr. Basha, do you have any questions?
Yeah, Pramod sir. First place actually there is a pregnant lady with the bleeding PV, means she continued pregnancy. What was the scenario? She was a pregnant lady and bleeding.
It is continued. Some bleeding is there in the first or second when she presented with us with the DVT and all these things. So pregnancy has continued. So we removed the filter after the pregnancy.
Okay. Because ideally in pregnancy, I think with the bleeding more than low molecular heparin, I think unfractionated heparin will be better, because we can able to have a control on bleeding, because patient is bleeding and low molecular heparin again we will not have a control. So unfractionated heparin titrated into it will be better, I think, mostly.
No. Initially 2 days we have not given any heparin to that patient. Just I put a IVC filter, we come down. So gynecologist has seen once bleeding has settled down, then we started with low molecular weight heparin.
Okay, right. And the second
cases, we have to continue until the until the pregnancy, because if you give a unfractionated heparins, again the heat and those problems will come because in the long term. So that's why we started with low molecular weight heparin and we can.
But heat is more common with I think low molecular heparin compared to unfractionated. And again, why did you start a warfarin on those patients? Better, because second trimester we can start a warfarin and
we can give warfarin, but end of the again third trimester we have to convert it because the warfarin has got long onset of action, if even offset also. So if they have got early, some gynecologist has to do section or some emergency has come, so then it is a difficult. So we continued in this patient low molecular weight heparin only.
Okay. And in the second and third patients, actually, if you're going to give a mechanical thrombolysis, like intrapulmonary or intrasubclavian, are going to give, what is the most common agent you choose and how much dose you give usually?
Usually we routinely we have given STK we have given 2 lakhs bolus, then followed by infusion for 12 to 24
so this
hours.
Is not directly
one
you give by IV, not directly by intrapulmonary or subclavian, not like that.
No. Catheter will be there at the site of thrombus.
Because we saw a catheter, but the angio pictures we didn't see actually. That's what I'm asking. It is catheter diator. In catheter diator, we give 2.5 lakhs directly, followed by infusion.
Infusion. Yeah, that's what.
And among the Novax post-lysis, which Novax usually you prefer? Which Novax usually among the Novax?
I prefer to give the younger patients, the bleeding risk is less, especially in DVT and pulmonary embolism, rivaroxaban I prefer. But in the elderly patient, we will choose apixaban. So that this is subclavian thrombus, the lady is 65 years, so we used apixaban.
Yeah, apixaban is always safe when compared to other thrombolytic.
Yeah.
Even the data very clearly says that the bleeding risk, everything is less with apixaban compared to this thing.
Yes, sir.
The only thing is double dosing, whereas for rivaroxaban you can take one shot, one tablet, 10 milligrams, whereas our apixaban is for two tablets. That is the only one thing what we have found in our practice. Otherwise, I think both are equally good, and apixaban, the chances of bleeding is less.
Even again, the dose modification is very clear with apixaban. If you want to reduce the dose means 5 milligram BID, but if you want to reduce the dose means either 3 out of 2, like 80 years and 60 kg.
Beyond 80 years, weight,
60 kg weight and
creatinine more than 1 point.
So that the guidance is very clear.
Very clear.
What in society, the use of apixaban, what the error commonly they do is when they fear of bleeding, they use apixaban OD, 2.5 milligram OD once a day. That is actually the common error. Usually once a day apixaban is not at all accepted. I even see in my my colleagues, somebody, physician, somebody, they usually put a OD because fear of bleeding. So they put OD, but that thing should be taught actually. Always it is BD. Okay, right. Yes, sir. I think I can proceed.
I think Prabhu sir can do his presentation. It was nice presentation.
Thank you very much for your wonderful presentation, Dr. Sarjan Basha and Dr. Pramod. I think you have made my job easier, and I being the last batsman, and you have scored a very good score, and I think I'll go for the last 10 minutes. Shaz case, please. Ravi Kesar, sir.
Yes, sir. Yes, sir. So you can can I share your slide, sir?
Please.
Yeah, you can share.
1 minute.
So before the slides start coming, we will be talking about the incidence of pulmonary embolism. And I can see all of you are in big centers, and you should be telling me what is the incidence of pulmonary embolism and death in your higher centers. Dr. Arvind, sir?
Yeah, by incidence, like, sir, we try to get all like as we have clearly mentioned, the incidence is very high nowadays. Even what we see, like the suspicion should be very high. So in a clinical practice, like patients having breathlessness and there are no very any other clinical signs, the pulmonary embolism should be the first diagnosis what we should see in our this thing. And we being at tertiary care center, as you clearly mentioned, the diagnosis, majority of them walk in with the diagnosis rather than we going for a diagnosis. And yes, definitely we do even get fresh cases where we try to diagnose it. Majority of them, like it will be like with the post-surgery, recent they would have undergone a TKR or hip replacement, following which they develop pulmonary embolism. We had recently a couple of patients, even in the immediate post-op period where we had post-hip replacement, the patient had a pulmonary embolism, DVT followed by pulmonary embolism, second post-op day. And it was almost massive with hypotension. So we took the chance of thrombolysis in such patient. I did the thrombolysis with Elaxim only. The patient did really well, because even the surgeon, I said very clearly that this patient is not going to make it if you're not going to treat the thromboembolism. Even it might bleed in your site, you might do a revision surgery, but to save the patient, we need to proceed with the thrombolysis. But luckily, the patient is doing really well. Post thrombolysis, his PA pressures have come down significantly. He did very well, and we discharged him on the 5th or 6th day. Even in the follow-up, he was doing very well, and we kept him on apixaban in follow-up. So, on some patients, even in spite of keeping them on especially this post orthopedic surgery cases. In spite of keeping them on adequate doses of this NOACs, they try to come back with the DVT and pulmonary embolism. Especially the awareness among the surgeons is very less, as Dr. Basha has very clearly mentioned. They try to keep them on a low dose, especially apixaban 2.5 once daily or 5 milligrams once daily. And that is one of the main reasons for the patients to come with the recurrent. The purpose is not at all being served. Ultimately, why we keep them on this molecule is to avoid this incidence, but somehow they low usage or the lesser dose usage, improper usage of the dose causes this problem, sir.
Thank you very much, sir. Slide, please.
Slides are visible, sir. These are the slides.
Yeah, that is only your, yeah.
So our topic was no thrombus, know about the thrombosis. So I'll be just discussing fast regarding the pulmonary embolism, starting from presentation to diagnosis. Slide, please. This was a distant relative, and they are all next to my farm. This young lady, she presented with dyspnea, continuous dyspnea for 2 or 3 days. I could not come to a diagnosis initially. I got the ECGs done. I checked her out and I was worried. She was a case of subfertility. She didn't have any kids. And I was worrying whether she had some family problem, husband and wife problem, and why she's becoming so dyspneic. I checked everything. Saturation was good. BP was good. The first initial 3 days. And she was telling, I feel very tired. I just can't explain. I feel thirsty. Something like that she was telling. And after 3 or 4 days, she came to me again with severe dyspnea. That is class 4, the last day. And severe fatigability. Serial ECGs initially were normal. The last ECG had just shown tachycardia. So still I could not put her in any place where, what is the problem exactly. Then on examination, she had tachycardia. She was dyspneic. The respiratory rate was high. Then I got really scared because she being a relative and he was my tractor driver's wife or something like that. Saturation went down. Then I thought we are going to lose her. So she had hypertension also. Then slightly I became panicky. Then cardiac sounds were okay. Then there were some scattered crackles on auscultation system. Then immediately one or two gentlemen over here only have echo over here at Darapur. So I did an immediate bedside echo. Then I could cleanse the diagnosis. The RV was quite dilated and she had a severe tricuspid regurgitation, severe PH. And immediately we started her investigating and we referred to a higher center like GKNM, which they preferred, and the D-dimer was elevated. I consulted with the cardiologist, interventional cardiologist over there, and they went on for a CT pulmonary angiogram. They said there was a occlusive thrombus in right pulmonary artery, and also a lot of thrombus in the upper, middle, lower lobe arteries, and also the multiple segmental branches. And they reassured her and they put her on immediate Elaxim was given 35 milligram. And she recovered very well. And post-procedure echo was absolutely normal. And she was gradually ambulated. I visited her once at Coimbatore. And she was placed on this parenteral anticoagulants. And slowly she was shifted to this oral anticoagulants, especially the NOACs, dabigatran was given. So this is, as I said, you have a wonderful place in Chennai where you all come, you get the diagnosis before you see the patient. Whereas we are handicapped and we have to use all our clinical acumen, all our risks, everything.
It's true, sir. True, sir. 100% true, sir.
And lucky, that day I was very lucky because I saw the echo and we could clinch the diagnosis. Yes, and that's how it, especially a young lady without any problem. Then probing into the history, then she gave history of an ankle injury 1 month or 2 months ago, and she was on a POP cast for 25 days. Whether after such a long time you can get a thrombus is still a questionable thing. And that was the only thing. She's the case of primary infertility. She was not on any pills. And very active lady. She milks the cows and she goes around the farm, does farm work and all that. Why did she get it? That is still a question. But anyway, now she's off the drugs. She was taking those drugs for around 1.5 years. Now she's doing good. So that was one of the challenging cases of pulmonary embolism which I had seen. And that's why I have shared over here with learned gentlemen like you. Next slide, please. Yes. So what are the objectives of knowing about pulmonary embolus? Know about the incidence. Sir said about the incidence, it's high comparatively. What could be the symptoms? What will be the presenting signs of pulmonary embolism? What are the models, clinical prediction models and algorithms or diagnostic methods? Next slide, please. So true incidence, I was going through a few articles. They say around 5 lakh people suffer from pulmonary embolism, and sometimes death is inevitable, and it goes by hours. If you undiagnosed, misdiagnosed pulmonary embolism, they die by the hour, and 0.3% of the general percent is estimated, and death is about 0.1%. So around 5,000 people die. 500 people died due to pulmonary embolism. That's what I could clinch. Next slide, please. So what could be the risk factors? Sir said beautifully that immobilization, previous or current DVT, surgery within the last 3 months, previous stroke or paralysis, and any instrumentation of the central veins, malignancy, congestive heart failure, autoimmune diseases. Air travel, I think this has become more common. One of my friends, pal, who was traveling to Jammu and all those places, and they all were cramped, all friends were cramped in a bus. They had to travel along nearly some 12 hours. Once he arrived to Bangalore, he had a DVT followed by early pulmonary embolism, but I think medications, he became better. He had some breathing difficulty because he was a young and athletic fellow. He came out much earlier. Thrombophilias, and especially in women who are morbidly obese, who have pregnancy, Dr. Pramod has wonderfully listed it out. And heavy cigarette smoking, we don't see much in our area, but heavy cigarette smoking, more than 20 cigarettes, can lead to pulmonary embolism and associated hypertension. So these are the things which we commonly know. Next. So most common symptoms, which even I had faced, was dyspnea, pleuritic pain in 44%, cough, and two-pillow orthopnea, then thigh pain, thigh swelling, wheezing, rapid onset of dyspneas, worsening within minutes and hours. So most common signs which we observe will be tachypnea, tachycardia. So one of the quiz was I'll be talking about. Tachypnea, tachycardia will be there, occasional ralls, and sometimes decreased breath sounds. And I think we should be very bold and auscultate everything before jumping into investigations. And sometimes the accentuated pulmonary component of the second heart sound, and JVP is sometimes distended. Next, please. So we have two criteria. One is Wells criteria and the Geneva score. More or less, both are the same, and we just have to see which percentage they come, the same symptoms which we assessed. Next, please. So Wells score will be clinical symptoms of DVT, leg swelling, red, pain, palpation, the Homan sign, classical, and other diagnosis for other than pulmonary embolism, then heart rate is high, that will be 1.5. Immobilization for more than 3 days, previous history of DVT, pulmonary embolism, associated history of hemoptysis, malignancy. If the score is more than 4, pulmonary embolism is likely, and less than 4, it is unlikely. This is Wells score. We have other. Next slide, please. We have the Geneva score. It is very simplified. Anything, any age above 65, we give a score of 1. Previous history of DVT or pulmonary embolism, 1. Then surgery or fracture within 1 month, again a score. Active malignancy, unilateral lower limb pain, hemoptysis, pain on deep vein palpation, lower limb. I think seeing all these scores, I think we have to put a lot of charts in our ICU. How many scores are there? I think this is one for pulmonary embolism. And I don't think I can remember so many scores at a time. So I think when score is above 3%, the Geneva scores is positive, and you know it is pulmonary embolism. Next slide, please. So D-dimer is a wonderful test. It is elevated in thrombosis, malignancy, pregnancy. It gives a positive thing, and you can go on investigating along with that. So normal results can definitely rule out PE, and role is high probability patients proceed to CT negative D-dimer can miss up to 15% of the patients in this group. So D-dimer is not everything, but definitely a positive can help you. Next, please. EKG. Anna, all of us, you know, we are very good and happy about EKG diagnosis of pulmonary embolism. And each and every tutors and professors have told us that S1, Q3, T3, and it is always not reliable. And usually they say the first thing is tachycardia, and you keep on searching for S1, Q3, T3, and you might miss a pulmonary embolism. And in severe cases, there can be arrhythmias, there can be RBBB, there can be some inferior Q waves, some inversion, and some ST segment changes. And if all these are there, definitely the prognosis is going to be bad. So S1, Q3, T3, I have seen even in my professor's daughter, she had a limb fracture, and she had a S1, Q3, T3. We used to take photos and preserve that ECG. And we see more nowadays, along with the WhatsApp group, you see a lot of ECGs also. Thank you. Next slide, please. They say a leg Doppler is much cheaper. You can identify a thrombus in a leg Doppler. If leg Doppler is there, then why go for all those high-end investigations? You can go for directly thrombolysis. Thank you. Next slide, please. So these are the two things which you notice in pulmonary embolism in the chest X-rays. The classical radiograph sign will be a Westermarck sign, like the arrow which has been pointed. Then the Hampton's hump, the typical wedge-shaped shadow which you see in a chest X-ray, which will definitely say this is a pulmonary embolism. Next slide, please. This slide is slightly borrowed, and because not many of us are familiar with the pulmonary arteries, aorta, when we see a CT pulmonary angiogram. So with the markings I have taken, you can see it has clearly marked the pulmonary artery, aorta, and you can see in the pulmonary artery, you can see the emboli, which has been marked with the yellow arrows. So one of the commonly cited benefits of CTA is to decide upon whether there is an embolus or what could be the problem because of the breathing difficulty. An alternate diagnosis also can be found with a CT angiography, and it can prevent unnecessary testing also. Next, please. The gold standard, just like our coronary angiogram, conventional coronary angiogram, the pulmonary angiography definitely shows the where you get the thrombus, and it is well marked in the arrows over there. Next slide, please. So consider the patient's risk factors, the history, the immobilization, the surgical aspects of 2 to 3 months. Still keep your mind open. The presentation of an acute pulmonary embolism with history of DVTs or previous history of DVTs or pulmonary embolism. And with the help of our D-dimer, CT pulmonary angiogram, we also can do this VQ scanning, ventricular quotient scanning. Then we do also this lower limb Doppler and conventional gold standard pulmonary angiography to click the diagnosis. And this will definitely help us and help in management by giving thrombolysis and continuing with NOACs. Next slide, please. So movement, keep moving, no sedentary lifestyle. Even most of the thing I've seen with the obese people are post-surgical, they tend to go slow. So this is a football time in Qatar. This is the Leib, that is the mascot. Be a good man and play football and ask your patients to keep moving around, move around. and keep them watchful on their health. I thank Emcure for giving an opportunity to talk with learned scholars in front of me, Dr. Arvind sir, Dr. Pramod, and Dr. Sarjan Basha. Thank you very much.
Thank you, sir. Thank you. It was a nice presentation, sir. So as we have very clearly mentioned, see this for the first case history where you have showed the 39-year-old lady who was presenting with I would like to even quote an example where I had a colleague of mine who traveled to Chennai for some reasons, and he said that he is breathless. So we had to go systematic. This is all what. So I did an ECG and echocardiogram. Both were perfectly normal, and I sent him across. He went back to his hometown. There was no, I didn't even contact him, and he even didn't contact him, but his breathlessness over a period of time persisted. So he went up to the level of he showed the reports what we have done here, and he consulted a local cardiologist there. There he was taken up for an angiogram itself, coronary angiogram, rather than repeating the echocardiogram. There they did even a coronary angiogram. They said it's normal coronaries. Oh. Then they did an echocardiogram. Then they found out that he had a massive pulmonary embolism, and he was thrombolized. So this is this intuition. See, once we have seen the case, and if it is following up with us, then it becomes easy. So then again, when they land up to the next consultant, again they think in that terms. So this man has evaluated all these things. We'll directly go for an angiogram. There might be a coronary artery disease for this, which causes breathlessness in an age of around 40-44. So we should not miss a CAD. That was the impression. So the intuition for this diagnosing or the diagnosis should hit the clinician very clearly the moment that the presentation, when there is an atypical presentation. So pulmonary embolism needs to be ruled out in all the cases unless proven otherwise, once they present with breathlessness. So this is a nice case what you have presented, sir. Good, sir.
Thank you very much, sir.
Thank you, sir. Thank you.
Yeah, that's what he mentioned, Arvind has mentioned. So especially if you take a patient for coronary angiogram, if you are not explained dyspnea due to coronary artery disease, all such type of patient, if dyspnea is not explained due to other causes, we have to undergo pulmonary angiography. Even if you do a coronary angio also, if nothing is found, that patient has to be undergo to explain what is the cause of dyspnea. It has to be undergo CT pulmonary angio. That is must. Even if we are following like that.
So lately, since I'm living in a town, we have a lot of people working from home. And all these guys were all living in Chennai, Bangalore, Cochin, in all beautiful places, having a good time with their friends in the evening hours. These guys now are working from morning 9 o'clock till 9 o'clock in the evening or 8:30. They don't have any other thing than watching their own parents, the TV, and they sit tight in their rooms. They all come with the history of hysterical hyperventilation. Breathlessness. So we use Daxid or Ancid Plus, these drugs to get their control. Everybody gets a chest pain. So I say it's vitamin D deficiency and all these. And they'll come, sir, I'm breathless. What to do?
Breathless. Some pain is there continuously. I'm working. And
sir, this is what happens in a smaller town.
Yes,
sir. Prabhu sir, actually, I am in a town only. Actually, I am in Tirupati and Arakonam. So we have this problem actually. But as Arvind also said, actually Harrison quote like saying pulmonary embolism is a great masquerader. That was a sentence given by Harrison. And the first differential diagnosis in Harrison for pulmonary embolism is ACS unstable angina. So any patient with the ACS unstable angina, actually coronary angiogram, because see, once we see the patient, they say initially the coronaries will be the echo will be normal. That is the problem. ECG will be normal, echo will be normal. The most common symptom is the dyspnea, and the most common is the sinus tachycardia. Later only S1Q3, RV strain, everything is going to RP. I had one patient actually. A patient without any risk factor. He came with no DVT, nothing. He came with just breathlessness. Actually, only mild breathlessness and and a vague chest pain. Initially, the chest pain predominated breathlessness. So I suspected young patient, actually around 35 years actually. And initially, I just saw ECG was normal, not even a sinus tachycardia. So, but that patient problem is he had a union, everything background. Everybody started asking what is the problem. and everything. So they are very familiar with the angiogram. So once I said chest pain is there, we have to see troponin negative, D-dimer negative. So I said it can be unstable angina. I took a coronary angiogram. It was normal. So I said angio is normal and we can wait. Next day, his breathlessness persisted, but I gave heparin. Actually, heparin first day I gave, so his symptoms mildly decreased, but it started increasing. And what happened is next day his ECG got changing. RV stain pattern came. I just did an echo next day. It was always getting somewhat getting enlarged. So I see since you said Arvind is luxury. I just shifted him from. I had still suspicious. Till that time, BP was maintaining. BP was 110 actually. So I shifted him from here to Chennai to take a CT pulmonary angiogram. From there, doctor radiologist he just called me and he said, "Sir, it is massive pulmonary embolism, sir. No flow is there in the pulmonary artery and only trickle of flow in the left pulmonary artery." So I said, just shift him. So once he shifted, once he came to my hospital, his BP came down to 198 like that. So I just explained them, thrombolysis to the tentative place, and later everything actually became all right. And on examination, he had a DVT. So as he said, from periphery, we go from DVT to pulmonary embolism. We have to check a DVT, and then we have to go to pulmonary embolism. That is the thing. Almost.
That's what, and independently practicing, and it's very difficult to explain that. The moment you do, see, you cannot ask echocardiogram for all the patients, also whoever comes with breathlessness. Yes. And the moment after doing breathlessness, they come on the 4th or 5th day. Again, if you insist them to do the echo, they will start doubting us, like why this doctor is asking again and again to do an echocardiogram.
That patient actually,
they won't even realize that the problem only gradually builds up, and all of a sudden the doctor themselves won't be able to diagnose the things on spot.
That patient, one finding I missed actually, which I again went and saw the echo. That what I missed is when after thrombolysis I went to the previous echo and saw the echo. I could able to see a thrombus in the pulmonary artery.
Oh, okay. Directly, MPX.
When the patient came with the chest pain, we think of chest pain. Unstable angina.
Like CAD. It's all again. It all lands up like with whom the patient lands up also. Yeah. See, if directly they land with the cardiologist, our mind will think only about coronaries, nothing more.
That time, see, RR is not dilated, everything, but there was a thrombus in pulmonary artery. That thrombus was probably I have missed it.
Right.
Most of the time,
right. We had a very good session. I think, Mr. Ravi, I think we had a very good session. All three were very different presentations. It's not like a monotonous presentations. Dr. Sarjan Basha, Dr. Pramod sir, Dr. Prabhu sir, all I think had a variety of cases and a variety of good discussion more than just monotonous presentations. I think anything else to be added, sir? I think if things are okay, we can conclude. Any other questions or anything like that?
Yeah, you can conclude.
Yeah, that's pulmonary embolism always is a clinical suspicion.
Clinical suspicion.
Something is not, patient symptoms has not resolved, then we have to rule out that thing. That is the dictum. Even if that's why we made this thing. The patient comes with chest pain, we did an angio, we see all these things. But at the end of time, when you are discharging the patient, do a CT, explain to the patient and do a CT pulmonary angio. If nothing is there, then we can send. That is the practice.
And to be reminded, I think we have to stick this well score and the Geneva score next to us, sir.
Next to us. Which reminds us.
This is all clinical diagnosis, sir. Pulmonary embolism is a clinical diagnosis. If you suspect only, then you can subject him for all these tests. Suspicion, high index of suspicion should be there. Even that ECG, STQ3, T3, that won't be only 10%. Tachyapnea, tachycardia, unexplained dyspnea cause, then you think of pulmonary embolism and rule out it.
Yeah. So I think, Mr. Ravi, I think you can give the conclusion this thing.
Yeah,
so we had a good session.
Yeah, it was really very wonderful session, sir, and the kind of the case has been discussed, and in many of our delegates, they have got a lot of insights. So more than almost 200 delegates those who joined today, and really they have enjoyed a lot, and they got something out of this, each and every cases, all the different cases today we have presented. And once again, thanks to our Venkatesh sir as well as Pramod sir and Sarjan Bhasha sir for wonderful case presentation. And also thank you, Dr. Alvin sir, for your very good insights and discussions for each and every cases. So for the job of Emcure, we're very thankful to you, sir. And also we want to just highlight that we have our rivaroxaban, that is Exafib, and we have apixaban, that is Prefixa. Exafib, last 2 years, it is #1 brand in the Indian rivaroxaban generic, and Prefixa that we have launched in just 2 months before, sir. So with this, thank you so much to all our delegates who have participated today and also our faculty. Thank you, sir. And good day.
Thank you.
Thanks to all. Good night, sir.
Good night.
Thanks, everyone.
Good night.